So let me start by just giving you an outline of what I'm going to talk about. Really, this is an overview. I'm going to just briefly mention some of the obsolete staging systems that we no longer use. I'll talk about the current staging systems, some of their advantages and disadvantages, and then try and bring some sort of conclusion to the presentation. So the first question we have to ask ourselves is why stage? And as surgeons, you all know why we stage. The importance is to classify disease together into homogeneous groups, groups that have a similar prognosis, that can undergo similar treatment, and more lately, in order to properly carry out clinical trials, we need once again to have a homogeneous population, and staging is one of the ways to achieve that. There are several different ways of achieving staging. There's the pathologic staging, clinical staging, which is what I'm going to talk about mostly today. Sometimes after therapy, there's a different staging system used, or restaging, and particularly after recurrence, restaging may be necessary. And I'm not going to talk about those two aspects of staging. So this is a list of some of the existing staging systems, and it's probably not exhaustive. And you'll see that, as always, when you have so many different systems trying to achieve the same object, none of them are ideal, and hence the reason why more and more are developed. As for pathological staging, we all know the old Edmondson-Steiner classification, which looks at the cells themselves and classifies them into 4 categories based on the idea that the more abnormal a cell is, the more pathologic it is, the more likely it is to be an aggressive tumor. But the problem is with pathologic staging is that there's not really a great deal of agreement between what you see in the biopsy and what you see in the surgical specimen. In one particular study, only 32% of the time did the two assessments agree. Furthermore, if you look at inter-observer variation, it can be as low as about 50%, which really limits the usefulness of the staging. And this slide shows you why. This is a hepatocellular carcinoma, and you can see 2 distinct populations of cells, and depending on where your biopsy needles happens to go, you may get different pathological staging. So pathological staging is really not used very much anymore, except that if a tumor is shown to be poorly differentiated on a biopsy, that carries with it a particular prognosis. And in some transplant programs, the fact of poorly differentiated has an effect on a patient's candidacy for liver transplantation. So how should a staging system be developed? The classical method is to assemble a large cohort of untreated, underlined untreated patients, to assess the factors that are associated with survival using initially univariate and then multivariate analysis, and combine the variables that are significantly associated with outcome according to the weights found in the multivariable analysis. So this gives you your system, and then you calibrate that by looking to see whether the expected outcome based upon the staging system matches the outcome observed in real life. And the criteria that are used to assess calibration, the important ones, are the C index, the Auroch curve, and the IHCC information index. And we'll talk about some of those as we look at the staging systems. This is the TNM staging for liver disease, for liver cancer rather, as you know. The old TNM staging, the HCC, UICC classification, which doesn't take liver function into account at all, doesn't take the patient's clinical status into account at all. And of course, in liver disease, in liver cancer, we have the underlying liver disease to be aware of. So the next step was the development of the simplified HCC staging, where patients were grouped into T1, T2, and T3. And this did take into account the severity of the underlying fibrosis, although again, it didn't take into account function. It simply looked at the amount of fibrosis present in the liver. Next along was the CLIP, Cancer of the Liver Italian program. And this was developed really based on what appeared to be appropriate cutoffs. It didn't use the classical method, but it had the advantage that it included the liver function in the form of the Child-Pugh score. And the tumor extent was assessed basically as greater than 50% of the liver or less than 50% of the liver, and that really didn't help us very much with regard to prognosis from small tumors. Alpha-fetoprotein factored into it, and portal vein thrombosis factored into it. And you can see, looking at the graph, that there was fairly good separation between 0 and 1, and 1 and 2, 3, but 2 and 3 were not well separated. So the clip never really got to be very popular. What did become popular was the BCLC staging, which I'm sure you're all familiar with, but I'd like to point out that the BCLC algorithm, as shown on the slide here, actually has two components. There's the staging system and the treatment allocation. Ideally, when you're developing a staging system, the treatment allocation should not factor into it. These should be untreated patients initially. And in the development of the BCLC, some of the patients were indeed untreated. They were the controls in, for example, studies of chemoembolization. But again, the BCLC did not use the multivariate, univariate, and multivariate analysis technique. It was really based on techniques that were, or rather treatments that were available at the time and the way they were applied at the time. The one big advantage that the BCLC gave us was that it clearly separated out so-called surgical from non-surgical, and in the non-surgical group identified why they may be non-surgical. Non-surgical for anatomical reasons, non-surgical for functional reasons, non-surgical for tumor burden reasons. Whereas in the past, many studies had simply lumped all of those together as unresectable. But there are problems with the BCLC. It's not the perfect system. It does not account for the heterogeneity in some of the intermediate stages between the smallest and terminal disease. The ECOG performance status, which is part of the staging system, is very subjective, and it does not discriminate between cancer symptoms and cirrhosis symptoms. If a patient is tired, is it because of the cancer or because of the cirrhosis? And because it includes the recommendations for treatment, in some cases it is perhaps too prescriptive. And so the net result is that there are many, many, many instances of deviation from the BCLC guidelines, even though the authors of the paper may claim that that's what they follow. So the next step was to look at some of these BCLC staging in more detail, and a group from Bologna looked at this and in BCLC-B and developed a staging system B1 through to B4 as shown on this slide. But again, this did not use the Cox regression to identify the factors that were important in the system. And really this was more on an empirical basis than the usual technique. And it also prescribed treatment, which again, as I've indicated, is perhaps a little dubious. The BCLC also, there was a lot of controversy over what to do with a single large tumor. Here's a study which looked at that. The upper blue line is BCLC 0 and A, in other words, tumors that are within the Milan criteria. BCLC-B, the light blue line at the bottom, is tumors which are beyond the Milan criteria. And the red line is the single tumor larger than 5 centimeters. And you can see that although there's clear separation between the three, the larger than 5 centimeter tumor, the outcome is closer to that of the BCLC-B than of BCLC-A. And the suggestion from this paper was that these tumors should be classified with BCLC-B. Another attempt to be more granular about the BCLC classification was BCLC-C, this NIACE score from France. And you can see the variables that were involved, the variables that came out in the regression analysis, and you can see the score that was attributed to each of those variables. And here, this is how they demonstrated the difference in outcomes. So along the x-axis, you have the score from 0 up to 7, and on the y-axis, you have the survival. And as you can see, As the score increases, so the survival decreases. So this gives some granularity to BCLCC. This is a fairly recent paper, and I haven't really seen much by way of validation of this. In Japan, where they see an awful lot of liver cancer and have been active in the field for many years, there are several different scoring systems available. Here is the Japanese integrated score, which is really quite simple. It's the anatomical extent of the tumor and the Child-Pugh stage. Simple in concept, but not simple in execution, because as you can see from this graph, it's actually pretty complex. This graph was developed on the basis of expert opinion, this scheme, rather than on the basis of a Cox regression analysis. Then along came the Hong Kong staging system. Now, what the Hong Kong staging system did was essentially based more or less on the idea of the BCLC, but not entirely the same. And they described 9 stages, stage 1 through to stage 5B. And once again, they were prescriptive in terms of the treatment that should be offered to these groups. And when you look at the survival, this is taken from the original paper, you can see that clearly stage 1 does quite well, but you can see that stage 4, which is the brown line, does almost as well in the long run as stage 1. And then you can see that in the stage, except for stage 4A, they all do pretty much, that except for stage 4A, stages 4, 5, and 6 all do more or less, 4 and 5, I beg your pardon, all do more or less the same. So you can see that you don't get very good separation except for stage 1. Nonetheless, the Hong Kong staging system did become popular in some studies. Before we get there, this is also from the original paper, and it shows that the Hong Kong staging system was had a better predictability, or rather better outcome, than the BCLC staging system. But is that a factor of the staging system, or is that a factor of the more aggressive treatment that the Hong Kong surgeons provided? It's probably related to the more aggressive treatment. When it came to external validation of the Hong Kong system in Europe, unfortunately, it didn't work. So what you can see here on the left is a graph from the survival curves, and you can see that stage 1, which is the blue line, does fairly well, but stage 2 does about as well. And when it comes to the other stages, there's no clear separation between them. And even when you shrink the Hong Kong system down to 5 stages rather than 9, there's fairly good separation between stages 1 and 2, but 3, 4, and 5 all have more or less the same curve. So the external validation of the Hong Kong system in a properly conducted study is still lacking. And even when you compare the 5 Hong Kong stages to the BCLC stages in the same cohort, you can see that the BCLC gives good separation between stage A and B, but in this particular case, C and D does not separate out well. From the US came the Messiah score. If you look at that equation at the top there, that's how you calculate the Messiah score, something you can do without thinking, I'm sure. And the graph below shows the survival curves, the observed and the expected. In other words, the calibration that I talked about a little earlier. And what you can see is that you get very good separation with the 3 curves. So what they did was they took all the data and they divided the patients into tertiles, and these are the outcomes. Very good separation. Messiah scores not that young any longer, but it doesn't seem to have achieved wide use. Here's just put some numbers on the calibration to show that the Messiah score gives a better calibration than some of the other systems. The higher the C score, the better. Then the most recent kid, the newest kid on the block, is the ILCA system. This was developed by the Italian liver cancer group. It looks fairly complex. There's a number of subcategories, the cancer staging, the Child-Pugh score, the ECOG score, and the AFP. And the number of points allocated to each stage are shown there. And this is from the original ILCA paper, and you can see that what they did was they took their cohort and the values achieved, all those point scores, and they divided them into quartiles. And you can see fairly good separation between the different quartiles. And once again, the two lines are the observed versus the predicted versus the observed. And so this looks to be a fairly accurate system. This has been validated, I hesitate to say external, it was another Italian group. And what they did in this study was that instead of dividing the scores into quartiles, they divided it into quintiles. So now you have 5 curves. And what you can see once again is when you look at observed and expected, they're pretty close to each other, and you have good separation between the different quintiles. So this looks to be, I won't say it's robust, but it looks to be as if it might be a useful system. So when you look at all of these systems, by the way, the Messiah and the ILCA did not prescribe treatment for the different groups. So the allocation of treatment modalities to various cancer stages for early stage disease at any rate is still largely empirical. BCLC remains the most commonly used staging system despite its problems, which are particularly the heterogeneity of stage B and stage C. And the newer systems use the BCLC as the starting point. Both the Hong Kong and the ILCA system did that, and then went on to develop their own variants. And the ILCA system, as I mentioned, is a promising system that seems as if it's widely applicable. It was developed in both Italy and in Taiwan. And the results from the two sites were pretty similar, so that it looks as if it's good in the East as well as in the West. Thank you for your attention.